this early. Okay. So
Only
can we
we've
start?
done one.
Can we have the first group presenting? Last week we had some group who did not finish with their presentation, or did they finish? I think a group was not able to finish with theirs. So can we have so how many groups have presented so far? Hello?
Yes, sister.
How many groups have presented so far? I think group 1 presented.
Hi.
Group 2 also presented. Hello?
Yes, sister.
So group 1, group 2 has already presented. So which group is yet to present? Can we have group 3? Has group 3 presented already?
No, sister.
Okay, so can we have group 3 sharing their slides? So we will follow them. What topic are they presenting on?
IMCI.
Okay, so let's hear you. I'm in a place I cannot be talking much, but so please pardon me, but I will come in when it's necessary. So let's hear the next group. So group members, let's be alert, and then class, let's all be alert and then contribute. Ask the questions, and then if you can also come in with some answers for them, we also support. I'm traveling. I'm traveling from Accra to Kumasi. So please pardon me if at a point the network is not really favorable. Okay, so group 3, are you ready? I think group 4 were the last to present. Group 3, if you are ready, please start sharing fast. And then group 5 will also be getting ready. If group 5 is ready, they can share their slides. Today we're supposed to have 3, 4 presenting. So please, let's hurry up. The one presenting can start talking whilst the other members start sharing. Try to share. So you can start presenting. Let's hear you. Okay, hello, we can hear you. So yes, yeah, please go on.
Yes, so we are group 5 presenting on vomiting, fever and diarrhea in pregnancy. In children. Sorry,
Children.
I'm Safia.
All right.
Yes, I'm Safia presenting on behalf of group 5.
Okay, the class rep herself is presenting, right?
Okay, this is our learning objectives. By the end of the lesson, Learners should know the causes, phases, and then types of vomiting and the appropriate management. Then classifications of fever, signs and symptoms, and their management. And plan A, B, and C treatment of diarrhea. Each pharmacological, non-pharmacological management and complication. Then we have vomiting in children. Vomiting is an oral expulsion of gastric content associated with contraction of the abdominal and chest wall musculature. So when we say vomiting, just the gastric content coming in with the intra-abdominal and the chest wall contraction. The muscles there will contract before the vomitus or the gastric content will come out. And then we have nausea. Nausea simply means sometimes when vomiting wants to start, nausea comes in before. But it's not necessary for you to vomit when you have nausea. So in nausea, you get some pleasant sensation. Maybe there's something you don't like, or there's an odor that you don't like, and causes you to feel like you want to nauseated or you want to vomit. So that you can either vomit or not. Then we have regurgitation. Regurgitation is where the food comes out without any intra-abdominal or muscle, chest wall contraction, muscles contraction. So that one is just like the stomach, and then the esophagus sphincter will just open voluntarily, and then the gastric content will come out without any pressure. Then we have causes of vomiting in children. We have gastroenteritis, we have rotavirus, we have food poisoning, urinary tract infections, appendicitis, interception, then bowel obstruction, and then pyloric stenosis. Then another one is the intracranial pressure. In case of maybe you have head injuries, this can also cause vomiting. And then we have meningitis, and then food allergy like lactose intolerance, and then motion sickness. These are some of the causes of vomiting in children. And then we have phases of vomiting in children. It occurs in two phases. We have the reaching phase and then expulsive phase. In the reaching phases, that one is there will be a muscle contraction, like the abdominal muscles and the inspiratory muscles and the diaphragm will contract simultaneously or in a coordinate way before the vomitus will come out. And then the expulsive phase.
Do you want to ask a question?
Then I'm already
Anita, your hand is up.
Okay.
Okay, please go on. Someone had a hand. Two people hand are up. I want to know if they have any questions.
Okay, sister.
From Anita. Okay, I think they are not even aware. So go on with your presentation.
Okay. So in the expulsive phase, this is where there will be relaxation of the upper esophagus sphincter, and it will release the pressure so that the vomitus and the abdominal muscles will relax so that the vomitus will come out. So that's it. Then we have types of vomiting in children. We have the dry hives or non-productive emesis. In the dry hives or the non-productive, you feel like vomiting, the intra-abdominal and then the chest wall diaphragm pressure will be there, but the vomitus won't come out. You have the urge, you vomit all right, but no gastric content will come out. And then we have the blood-stained vomit, and that is termed as hematemesis, and that is bleeding from the esophagus and give the vomitus a bright red color. So that is it. And when it is in the stomach, it can be dark, maybe due to the iron in the blood. And mostly those with peptic ulcer or gastric ulcers mostly have that issues. Then we have the coffee ground vomiting. In the coffee ground vomiting, the upper gastrointestinal bleeding causes exposure of the iron in the blood to the. So when there is blood in the stomach, or maybe due to peptic ulcer, the iron in the blood mixing with the gastric content causes the vomitus to be like a dark color, coffee ground color. It will be a bit dark just because of the iron there that has been oxidized, or that the iron has been removed from it, or oxygen has been removed too. Then we have the bile-stained vomiting. And it is persistent severe vomiting after eating a heavy meal may lead to a bowel vomitus, which is usually yellow in color. Bile-stained vomitus is seen in bowel obstruction and bowel reflux. Bowel mixes with food in the duodenum. When small intestine is obstructed, its contents are exposed along with the bowel. Surgical removal of the bowel bladder, gastrectomy or gastric bypass surgery, etc., can cause reflux of the bowel in the stomach and lead to the bowel stained vomitus. So this is where the bowel is being stained also with the vomitus, giving it a yellowish color. And mostly they said it's when there is obstruction in the bowel can also lead to this. Then we have the fecal vomiting, also causing when there is a intestinal obstruction too, can also cause the fecal content coming out into the abdomen and into the stomach, and then you vomit it out as a fecal matter. Then we have the projectile vomiting. In projectile vomiting too, the vomitus come by force, and it could be also by pyloric stenosis, whereby there is an obstruction in the pylorus, or when there is a tumor in the esophagus or in the, that can also cause projectile vomiting. Then we have the spitting up. Small volumes, less than 5 to 10 mils of vomit during or shortly after vomiting, often red-paired, typically caused by rapid or overfeeding or breastfeeding. So this, you can mostly see it with the children. When you overfeed them, then you see that some of the breast milk or something coming out from their mouth, because of maybe sometimes due to overfeeding, or when you try to let them belch. Then we have infant regurgitation. That one, the baby can vomit like 2 times per day or 3 times, because sometimes they have immature gastrointestinal tract, so they may not be able to digest the food very fast, so they can easily takes the food out. So physical examination findings, so go to the hospital or to the health center to find out what the problem is. Sometimes vomiting mostly is not a disease, but sometimes it's symptoms or signs of a disease. So you check out for fever, which is indicating a sign of infection. Then you look at the hypotension, the tachycardia, then volume loss. And so that one will be let you know maybe there's dehydration or something like that. So then you inspect. Under the inspection, you try to check the consciousness of this baby or the child. If there is intracranial hypertension due to maybe brain injury, or there's a tumor causing the vomitus, then the meningitis, which is metabolic disorder, toxic injection, and then we have weight loss. Eating disorder can cause the weight loss or obstruction like pyloric stenosis. Then you check the neck and then the head. if it is meningitis or this baby cannot turn well, you also suspect meningitis. Then you look at the red
So
body.
what you are presenting, you see, what you are presenting is just telling us about the differential diagnosis or the suspected causes of the fever, other suspected causes. Are you getting it?
Yes,
so
sister.
once you are assessing the client, if the baby or the child who has been reported to you has been vomiting over time and then has fever, then you know that you should look out for signs of what? Infections. Then you know that it may not be just the spitting up or just an allergic reaction. When there is fever, then we can tell that there is some form of infection somewhere. So you have to look out for that. Are we getting it? Okay. So it means that when the child has hypotension too, then you also have to look out for other signs like the tachycardia, and then it means that it has to do with what? The volume loss. It means the child has lost so much fluid. Then it means you are not going to ask the woman what the duration of vomiting is. How long has the child been vomiting? If the child has been vomiting for a long time, then you can tell that this child is likely to what? Be severely dehydrated, so you know what to do for the child. So the physical examination for a child who has been vomiting over time is very, very important. So please note this carefully. Note this area carefully. Are we all there?
Yes.
So follow it carefully and then try to ask all the questions that you need to ask. All right.
Send it out.
So please go on.
The right. Send it out.
So you have to also check the head and the neck, and then the red bulging tympanic memory can be ear infection. So when you see these signs, it could be an ear infection. Then bulging anterior frontal or nuclear rigidity, which indicates that this child may be having meningitis. In a case, maybe when you see a baby with anterior frontal bulging, or then the baby or the child cannot turn the neck, you should be suspecting meningitis. Then erythematous tonsil, then upper respiratory tract infection. So when you see that this baby, when the baby opens the mouth and you see that the tonsil is very red, you should be suspecting some kind of respiratory tract infections. Then cardiovascular system, under the cardiovascular system, you look at tachycardia, an infection or dehydration. Then under the abdominal examination, still under the physical examination, abdominal distension could be an indication of obstruction or mass or congenital abnormalities. Organomegaly, maybe there is some of the liver is swollen or is big, and you could see it abdominal, you could see some veins, and then you should be suspecting there is an obstruction or something. Then the bowel sound too, you have to also check the bowel sound. If it's high pitch, tinkle, it shows that there is an obstruction, and if it is absent, then it could be the ears. Then guiding rigidity or rebound tenderness could be a sign of appendicitis or peritoneal inflammation. Then you go to the skin and the extremities, petechiae or petra, serious infection. So that means when you check the skin and you see that it is reddish or there is accumulation of blood maybe under the skin, it looks reddish, you should be checking maybe there is a sign of skin infection. So then you check the skin tegel and capillary refills too. So when you check and then you try to retract the skin and you see that it's not retracting, you check the capillary refill and it's also not good enough, you suspect dehydration. Then jaundice, which is also a metabolic disorder. When there is yellowish skin or eye, you should also suspect metabolic disorders. And then rashes could be a sign of allergy or food intolerance or a viral. Then these are the red flags under the physical examination that you should also notice. The following findings are of particular concern when the baby is lethargic or is restless. And then the baby is crying, you cannot console this baby, and there's bulging fontanelle in an infant. Then the nuclear rigidity, whereby it cannot turn the neck, the photophobia, it cannot tolerate light, and then there is fever in older children. Then we have peritoneal signs or abdominal distension, which is other name for surgical abdomen. Then when there is persistent vomiting with poor growth or retardation or development. So these are the red flags you have to notice when you are doing the physical examinations. Please, we are done with vomiting and we are going to the next topic, which is fever in children.
You are not done with vomiting.
Okay.
You have not done a thorough assessment, because remember you were talking about the different forms of vomitors and then mode of vomiting. So now you have to go back. When the woman comes to you with a child who has been a report of a child who has vomited over time, then you need to ask a lot of questions. How long has the child been vomiting? You also need to find out the color of the vomitors. Are you getting it?
Yes,
you want to look at the color of the vomitors. You have not asked all that questions. And then, is there anything that triggers the vomiting? Do you have a particular time? We want to find out from the woman, do you have a particular time when the child vomits? Have you really identified any special food that normally triggers the vomiting? You need to ask all those questions. So until you have found out those answers to those one, you cannot really conclude. Although the other signs and symptoms are going to tell you that the child is likely to have one or two, and then you can conclude and then follow up with your other lab investigation. But until then, you cannot just conclude on just the physical examination you are conducting. Are we together?
Yes, sister.
So please include that in your
yes, you add it.
Slide.
Yes, sister.
Okay. So let's go.
Okay. So we are on fever in children. Fever is a common complaint which is usually related to an infection or viral, bacteria, or parasitic origin. It may be a valuable guide to the diagnosis and severity of infection. So fever is not actually a disease, it's a symptoms, and it could be some kind of disease that is, or an impending disease that wants to show up and is giving you the signs. So it could be an infection, just like it said. So fever is defined as an auxiliary temperature above 37.5 degrees Celsius in children and adults. Often needs urgent attention, especially when the patient is restless or delirious. Not every fever is due to malaria or typhoid. Every fever should be investigated and treated appropriately. So any temperature that is above the normal 37.5 is considered as fever, both in adults and then in children. And especially when there is a signs of maybe restlessness or the person is confused or the other. And it could not be only malaria, it could be also other causes that is causing the fever. A thorough history, physical examination, and appropriate investigation would usually reveal the causes of the fever. In neonates and elderly, severe infection may be accompanied by fever. In infants and young children, fever may be associated with convulsion, collapse, or coma. So we have causes of fever in children. We have the viral infections. We have the bacterial infections. We have fungal infection, parasitic infestation, hematological malignancy, e.g. lymphoma, and then leukemia. So these are the causes of infection. It could be a virus, it could be a fungi or a parasitic infestation, or it could be some tumor, or could also be some tumor that is causing the fever or the spike in body temperature. Then we have signs and symptoms of this fever. The symptoms could be chills, or there will be rigor, where the baby can be feeling warm, and then small time, then you'll be feeling chills. And then that's the signs at the temperature, the one that you can vividly check on your own that actually this patient is having fever, because with the symptoms, the mother can tell you that the baby feels cold, the baby is shivering, or the baby will shiver small time and then will feel hot sometime. But it is a sign when you check with your, you check as a health worker, you know that actually this baby is having fever. Then evidence of dehydration, which is the sunken eyes, that will show you, or that will give you the sign that actually the baby is also suffering from kind of fever with maybe diarrhea. Then evidence of underlying condition, which you will ask the mother if there is a condition before that, or maybe this baby is suffering from some other condition that the mother is aware of. Then there will be tachycardia, then tachypnea. Then investigation that you look out for when there's evidence of fever is full blood count, and then blood film for malaria. You can check for the RDT2. Then culture for urine, blood, sputum, ear, throat, wound, or cerebrospinal fluid. So if this baby is having some wound or throat infection, which you have to take these samples and then check if that is causing the fever. Further, why then?
Okay, so
Yes,
so it means that the same laboratory investigations were supposed to be done for a child who reported with continuous or persistent vomiting.
yes, sister.
So you'll be able to rule out whatever bacteria that is causing that, or whatever. If it's a viral infection, then we will be able to identify that. But this you did not do for the vomiting, or you doing the laboratory investigation for both the vomiting and then the fever.
Yes, sister. Since it's
It is for the two.
hello, sister. Because we are doing
All right. All right. So
yes,
go
so
on.
yes.
Okay.
So the assessments that you have to probe more into the causes of the fever. When assessing body temperature, it is important to consider patient-based and environmental-based factors, including prior administration of antipyretic and recent environmental exposure. So when you are checking the temperature of this baby to check if there is actually fever, you need to ask the mother or the mother some few questions to help you with assessment. Is there maybe you are giving the baby some antipyretic, or there is something causing it, maybe a change in weather or any other thing, or climate change that is causing the fever, or there is some kind of disease that the baby has that triggers the fever. Then body temperature should always be evaluated in the context of other vital signs and overall patient presentation. Even though you are checking for the temperature, you are also looking at is the vital and the pulse okay, is the blood pressure okay, how is the patient present, how is the baby presenting, is it lethargic, is it restless, is it obnoxious? This to be assessed to actually know what the next line of treatment. Then method of body temperature measurement. Due to temperature variation between body sites, ideally the same route should be used for ongoing patient observation as to allow for accurate temperature trend evaluation. Then you document it in the emergency medical records. So just for you to know, to get a good assessment, you have to, for ongoing assessment, you have to, if you are using the ASILA, you should use the ASILA so that you can be able to get the adequate assessment or observation that you are looking out for. And if you are using the tympanic or the here one, then you should also be continuous with that one so that you know if there is variation or is the same thing. But if you are using different routes, it can change your observation, what you are actually looking at. Then we continue with assessment. The 0 to 3 months is ideally to use the axillary route, which is the armpit. And then 0 to 3 and use the rectal route if it is requested. But mostly the rectal route is not always ideal because sometimes the child may have some kind of coagulopathy or there's a problem with low platelet. So maybe, or there's trauma in the perineum, and then when using the rectal route, you may cause more harm than good. So it is only when you think that there is no problem with the child that you can use the rectal route. Then above the 3 months, you can use the tympanic route, which is the ear. Then if the patient has been exposed to cold condition, allow for adequate time for patient equilibrate to room temperature before measuring body temperature. Both axillary and then tympanic routes measures temperature lower than the true core body temperature. So if like the baby or the child is feeling has been exposed to maybe cold condition, when you are checking for fever, you want to check the temperature, you should allow the temperature to be in a room temperature before you check, because it may alter the actual values that you are looking at. And if you are using the axillary tool, sometimes it's lower the temperature you are looking for in a case when this child is cold already. So you should allow for a room temperature before you use the axillary and the tympanic route. Then classification of temperature. We have the low temperature, which is the hypothermia. That is less than 36.5 degrees Celsius in the neonates of 1 month. And then the pediatrics is greater than 36, less than 36.0 degrees Celsius. And then we have the pneumothermia. The pneumothermia is a normal temperature, which is in neonate, it is 36.5 degrees Celsius to 37.5 degrees Celsius in the neonate. 36.0 degrees Celsius, 37 degrees Celsius. Then we have low-grade fever, which is the
mute yourself. Abba.
Is 37.6 to 37.9 degrees, and then the pediatrics is 37.6 degrees to 37.9 degrees Celsius. And then the fever actually, which is the hyperthermia, the high fever, greater or equals to
Anything.
Now you diagnose can be based on the clinical senses.
Greater or equals to 38.0 degrees Celsius. Hello, sister. Please mute your mic.
Jesus.
In the pediatrics, is greater than or equals to 38 degrees Celsius. So this is the classification for the neonates and then the pediatrics. So we go to the management of fever. In a case when you see or there is a fever case with the children and it's being brought to you, this is how you manage them. The management, we have the objectives, what you are trying to, your objectives, what you are your goals to bring down the temperature to a normal. So you reduce the body temperature to normal. That is your goal or your objective. Your first line objective to bring the body temperature to normal, and then to relieve the symptoms. Since we said the fever is the symptoms of the disease, so you are trying to relieve the symptoms the child comes with. And then you have to treat the underlying cause of the fever. Whatever is causing the fever, we try to see how down there. Then we have one, the non-pharmacological treatment. So this, you are not using drugs. You keep the patient well hydrated with fluid. Example, water, juices, light porridge, rice water, or coconut water. So you can use that to also, and you can also put a sponge. And then you also maintain nutrition. Maintain nutrition, continue breastfeeding in baby. So if it is baby, you continue to breastfeed so that the baby can get adequate water. Then you also tap a sponge the child with lukewarm water, pour it over there, and then leave it to dry on the skin. So this is in a case where hello sisters.
Please increase your voice.
Okay, sister. Okay, so you tapping on the child. So in the case when you are trying to tap his sponge, and then you see that the baby has rigor, that one you have to, after you pour the water on them, you have to cover them, because the baby goes in episode of rigor, chills, and so you don't have to do that, because it goes to rigor again. So you have to check that one when you are tapping sponge or you are pouring the water over them. You have the pharmacological treatment.
Ishan, Sarah,
Oh, so
you're making noise.
some people mute themselves. Can you mute yourself?
We are now on the pharmacological treatment. Under the pharmacological treatment, we give paracetamol oral, children 10 to 15 milligrams per dose. Then you may repeat this dose 6 to 8 hourly as necessary. Then note, do not give aspirin to children under the age of 16 years. To control convulsion with, you can control the convulsion to diazepam. Then prevention. A patient's surrounding environment can greatly impact their ability to maintain an otherwise stable temperature. So this, if the environment, maybe you could ask the mother they stay, or maybe it could be that they always close their windows and this, and there's no, the air cannot even come into the room, and the room is always hot and the rest. So you can even advise the mother to always open the windows for fresh air to come in, so that it can reduce the temperature. So this is a form of prevention or advising or counseling the mother when there is fever in the babies.
Madam Sarah, you are making noise.
It's everything.
Hello, sisters. Please, can you hear me? Okay, we are now in diarrhea in children. Diarrhea means passing frequent, loose, watery stool 3 or more times in a day. Diarrhea is often accompanied by vomiting. It is very common in children. The commonest cause in this age group is viral. There is therefore no need to prescribe antibiotics. Fluid loss occurs frequently in children because of their size. If this is not corrected, it may result in dehydration, which can be fatal. In children, other diseases like malaria, pneumonia, air infection, UTI may cause diarrhea. So that is diarrhea. It's frequent passing of stool more than 3 times in a day. And mostly in children, it's common, especially babies when they breastfeed a lot. So, and mostly, and it's in children, it is viral. So you don't need to give antibiotics. You just have to give the oral aeration therapy. But in a case if it is infective or if it is due to bacteria, then you can give antibiotics to combat it. Diarrhea in children continues. Examine the child fully to make sure there is no obvious cause of diarrhea. The presence of fever usually indicates an underlying cause. Never take the complaint of diarrhea lightly. So in a case when there is diarrhea, and then you should have to check if there is a cause for this diarrhea. That is if it is due to the viral or due to the bacteria or something, if it's due to virus. And then you have to also know if there is a cause for this diarrhea, if it's not due to the breastfeeding or anything that is causing it, but there is a cause that is triggering the diarrhea because it's a symptoms of a disease. So you have to also check that. And then you always ask how many times the patient has been to the toilet and the day before, and the texture of the stool. So if it is a loose stool, or how many times, 5 times in a day, and it's very loose, and then even maybe there is vomitus, or the child is vomiting alongside with the diarrhea, you also have to ask. Then to one person who usually passes to once in 3 days, a motion every day seems like diarrhea. So someone who doesn't pass, like a child that doesn't go pass every time. In a case, maybe they go 2 or 3 times in a day, they feel like it's diarrhea or they are having loose too. So they may normally come to the health center to have themselves checked. Or the mother will be worried that my baby doesn't pass through like that, but this time he's going 2 or 3 times in a day and he will be worried. Giving antibiotics may cause or prolong the diarrhea, except in special circumstances. So some antibiotics normally causes you to pass frequent stool. Something like ciprofloxacin can make you pass stool more than necessary sometimes. So sometimes you could ask the mother that have you given your child any antibiotic? Is there any drug that the baby is taking? Maybe that could be the reason for the baby passing frequency. When malnutrition causes diarrhea, this in turn also causes malnutrition, setting a vicious circle. Never give enema or lack patient with diarrhea. So in this case, malnutrition, when you are not taking a balanced diet, it could cause a diarrhea, and you even passing more stool can also cause that malnutrition. And then it will be like a circle. You just be passing because you don't eat well. You be frequent stool, and which will not give you the body mass that you actually need. And then someone who is also passing frequent stool should not be given an enema or any form of laxative because it will also cause more of the diarrhea to go on. And we have the causes of diarrhea in children. We have the viral one, which is the rotavirus. Example is the rotavirus. And then we have bacteria causing diarrhea. Then we have protozoa, the amoeba. Then we have the side effect of some medication like the penicillin causing it. Then symptoms. We have frequent watery stool. We have blood or mucus in the stool. Then we have presence of fever. We have reduced urine output. Then we have vomiting. So these are the symptoms that the patient will present in, or the baby will present, the mother will tell you that these are the symptoms that is going on, that there is frequency to cause mucus in the stool, and then the sign of fever. When I touch my baby, I feel that the baby is always hot, and then there is reduced urine output because diarrhea comes, and especially when it is watery, fluid. So definitely the urine output will also be very small. Then diarrhea comes with vomiting sometimes, especially when it is due to bacteria.
You were watching the
Then we have signs of diarrhea, which the health worker will observe after the symptoms that the mother already spelled out to you. You can see that from the baby or the child, you can see that there is dry mouth, and then the eyes sunken because of the frequent passing of loose stool or dehydration. Then the baby will be very weak, or they will be lethargic, and then unconscious. In the case when the diarrhea is so
Charity, mute yourself.
You may be feeling some kind of feeling unconscious and like passing out. And then the skin will also, there will be skin tears. The skin goes back slowly after pitching. So that is the sign that you will look at. Then investigation that you confirm your diagnosis as a full blood count. You make preparation for food. Food.
it may be there.
Blood sample, malaria parasite. Then stool routine examination to check if there is a typhoid or anything. Then stool for culture and sensitivity. You can do the routine one, then you can do the sensitivity. Then you check for blood urea or creatinine, which is check for the treatment. So after going through your lab investigation, these are the treatment objectives that you are looking at. Your first line is to prevent the diarrhea, and then you try to also replace the fluid that is being lost. Then you have to maintain nutrition so that the electrolyte that is being lost can be regained. Then you have to maintain personal hygiene. It could be maybe due to cholera or something that is causing or poor personal hygiene that is causing the diarrhea. Then you try to eliminate infecting organisms where appropriate. So teaching hand washing and the rest can also be. Then we have the non-pharmacological treatment. The non-pharmacological treatment is that you are not using any drugs. So you are keeping the surrounding clean. So this is just like you are a form of education. You educate the mother to keep the surrounding clean, improve their personal hygiene. You counsel them on personal hygiene. You teach them hand washing techniques, and then home-based fluid intake. So you also teach them on this home-based fluid intake. They can boil their water and then take more water, and then coconut is also good for you to be taking once in a while. You could educate them on that. And then you maintain diet. They should also eat good nutritious meal and then balanced diet. Then pharmacological treatment. So this is the treatment for like you are using drugs. Then you can use the fluid therapy. So in this one, this is mostly viral. You are using this treatment like a viral one. You don't use any drug or antibiotics. So child with dehydration that is less than 5%, you get a plan. Get treatment plan A. There's treatment plan A for that. And then child with mild, moderate dehydration, 5 to 10%, get treatment plan B. Child with severe dehydration, get treatment plan C. So in the treatment plan A, a child that is less than 2 years of age, you get 500 ml or more of oral hydration salt. And then if they fit to 10 to 100 ml, then a child of 2 to 10 years, 1,000 ml or more, then 100 to 200 ml for an extra stool pass. Then greater than 10 years, 2,000 ml or more. That is a normal. And then if there is an extra 2 that is passed, you give 100 to 200 ml in addition. Child should continue to feed with the ORS that you are giving. The child should still continue to feed. Then you ask the mother to return to the health facility if child gets worse. In a case if this is not stopping, or there is more fluid that is being passed and it's very watery, the rice water and those things, you can still ask the mother to bring the child health facility. Then if vomit repeats, also is repeating, like the diarrhea comes with vomiting, then you ask the mother to bring, and then the sign of the baby is feeling tasty every time and he is eating poorly for 2 days, you ask the mother to come back to the health facility for further treatment and then probing. Then you instruct the mother on how to prevent the diarrhea. In a case maybe the poor personal hygiene, like we discussed earlier, you could also teach this the mother on personal hygiene and then how to even do the ORS in the house. So we have the plan B. Check the age, and then if the child is less than 6 kilos, then up to 4 months, or is 6 to 10 kilograms, that is 4 months up to 12 months. Then we have, if the child age is also 12 months up to 2 years. Then if it's the plan can be, and then if the age is up to 5 years, to use the 12 to 9 kilos. Then this is the amount of ORS that you should use. The 200 to 400 ml for this age group, and then the weight, and then 400 to 700 ml for this age group. That is the 4 months to 12 months with their weight.
Special course in pediatrics. And
then if this child is also 12 months upwards to 2 years, and with this 10 to 12 kilogram in weight, then you have to use they have to take 700 to 900 ml of ORS. And also, if this child is 2 years up to 5 years, and then this is their weight. So this one, you are using their weight to check. And then you give 900 to 1,400 ml of ORS for this age group.
Okay.
So that is it. We have the treatment plan C. The age is less than 12 months. Give ORS 10 ml per kg in 1 hour. Then give in 5 hours. After 1 hour, you give in 5 hours time. Then child whose age is 12 months up to 5 years. The first 30 minutes, you give 30 ml, and then the next 2 hours, you give you give to the next 2 hours. The child of 70 ml of ORS per their weight per kg. Then how to prepare the ORS. Dissolve the content of 1 sachet of ORS, 600 ml yourself. The child or the adult should drink as much as
why?
The child or adult
Agnes, mute yourself.
Not all.
All right. So the child or the adult should drink as much as you want. If the child vomits, the mother should wait about 10 minutes and give again. So this is how you prepare it, and then you educate them on how to prepare the ORS at home. So if they don't have anything to measure it, they could use the sachet water, yes, to mix them. And then you give the child as much as the child can take. The complication of severe diarrhea. Severe diarrhea may lead to marked fluid loss, accompanied by loss of potassium. There's hypokalemia of diarrhea, or it can lead to an impaired renal function, leading to acidosis and elevated blood potassium level. So these are the complications. There may be fluid loss, and then when there's fluid loss, you can have low potassium. And then if there is renal problem, you can have acidosis and then low potassium. Pharmacological treatment. In a case when we have the anti-infective therapy. Hello, sister. Hello, sister.
Yeah. You know which one is attributed to which one. Electrolyte that the child looks mad. And when there is diarrhea, which of the electrolytes that the child. So please note these ones too down.
Hello, sister.
Please, can you go over?
Please, which one? And sister is saying something, but I can't hear. I don't know.
No, please, what sister just said.
Please, what did sister say, please? Is it under here? Should I go over here, sister?
It's under the when you lose a lot of potassium. That side.
Not the pharmacological treatment. Go back. No, please wait.
You are drinking of
at this place. No, go back.
Okay. Okay.
Not here.
Okay.
Here.
Here.
Not here. Go next slide. Here, it's okay.
Okay.
This is where she was talking about.
Okay, sister.
So we should take notice of the hypokalemia and then hyperkalemia. That was what I heard say. Then her network, I couldn't hear again.
Okay, sister. So you want me to? So you want me to go over this, sister?
Oh, so say something about it. About the hypokalemia.
Okay.
And she said she's traveling, so her network will not be stable. She just made mention of it, and I couldn't hear her really.
Don't eat again.
But you can go on, maybe in case she comes back, then we'll ask her.
But is there anything that you want to find out there?
No, it's rather sister who was emphasizing on the hypokalemia and hyperkalemia. Then her network wasn't good. So maybe you can continue. When she comes back, then we'll now find out what she was trying to say.
All right. So we have the pharmacological treatments, the anti-ineffective treatment therapy. Then we have the viral diarrhea. So in the case of the viral diarrhea, you don't need antibiotics. You just give the ORS. And then in the bacterial diarrhea, you give ciprofloxacin, oral, 15 milligram per kilogram, or 12 hourly for 3 days. And then when it's amoeba diarrhea, you give metronidazole, oral. So when the child is 4 or 7 years, you give 200 milligrams, 8 hourly for 5 days. And if this child is 0 to 3 years, you give 100 milligrams, 8 hourly for 5 days. So this is the treatment, the pharmacological treatment for when it is bacterial infection or amoeba diarrhea, or when it is viral. Then we have cholera. Under the cholera treatment, you give erythromycin oral 1 to 5 years, 125 to 250 milligram, 8 hourly for 5 days. And then when the child is less than 1 year, you give 62.5 to 125 milligram, 8 hourly for 5 days. And then you complement it with zinc supplementation for diarrhea. If the child is more than 6 months, you give 20 milligram per day for 10 to 14 days. And if the child is less than 6 months, you give 10 milligram per day or daily for 10 to 14 days. So please, we are done. Thank you. And these are our references, and then the group members. And these are our group members too. Thank you so much for listening. Please, if you have any question, kindly bring it up. Hello, sisters. Please, do you have any questions for us? Hello, sisters.
Yes, sister.
Please, do we have any question for us, or we can take off our slide?
Please take off the slide.
Sister Yando. Some kept their questions in the chat box. Check there. Sister Yando. Please, can you post your presentation?
Yes, sister. Hello, sister. What
Please,
are you saying, please? I can't hear you. I
You
think my
can please
network
post it on the page for us.
Sit down. Sit down. Pineapple.
Madam Susanna, please off your mic.
Hello, colleagues. Good afternoon. Please, Ma Rahel says she's trying to join back, so her network is actually disturbing her. So group 3 can go ahead and start their presentation while she tries to join us. Thank you.
Thank you so much.
Sister Martha, Sister Doris, please check your microphone.
I think this issue, it should be addressed in a way that some people don't know that their mics are on. So those who know them personally, you call them on phone and tell them their mics are on, so they should off it. Because some of them, I don't think
People don't have
it's now.
all in them.
But please, are we not having co-host today?
Hello, sisters. Oh, who's pronouncing? Okay, good afternoon. We are group 3 presenting on IMCI case management on the new needs. Yeah, Mr. Please go to the first slide there, objectives. The objectives. Okay. So this is our objectives. So we said by the end of the presentation, students will be able to define IMCI, state the components of IMCI, explain why IMCI was implemented and why it is better than the single management approach, and then state the principles of IMCI, identify who can use IMCI, state the steps in integrated case management, and then state the advantages of IMCI. Please, next slide. So we are saying that IMCI is an integrated approach that focuses on the health and well-being of the child. And then its aim is to reduce preventable mortality, minimize illness and disability, and promote healthy growth and development of children under 5 years. So we are saying that the IMCI case management and integrated approach, it is a lot of cases brought together to focus on the well-being and then the health of children under 5 years. Under 5 years. And then we are saying that the aim for this IMCI is to reduce preventable mortality. There are some of the deaths that can be prevented right from the home to the health facility or to the health center. So the aim is to reduce this preventable death or this preventable mortality, and then reduce illness or minimize illness and then disabilities, then promote the well-being of the child. And then we said the IMCI both it includes preventive and then curative elements that can be implemented by families in communities and in health. Yes.
Please, the IMCI, you didn't tell us where it came from. We just heard we are presenting on IMCI. Can you tell us the full meaning?
Oh,
so that will be a little bit open.
Okay, integrated management of child health illness. Childhood illness, please, are you okay?
Okay, thank you.
Integrated management of childhood illness.
Okay.
Can I continue?
Yes, sir.
So we are saying that it includes both preventive and curative elements that can be implemented by families in the communities and then in the health facilities. So it's a case management that can be prevented in the community. So in the communities, in the sense that there were days that we had these CH veins in our communities who were giving some basic drugs to treat children who fall sick. That is at crucial times in the communities before they are brought to the health facilities. So this thing can be prevented there. And then in our families, by the families in a situation where there is prompt response to the child's illness, so that they can be early referral to the health facility for prompt treatment. And then we said this approach was developed by the United Nations Children's Fund and then the World Health Organization in 1995. Please, the next slide. So what are the components of IMCI? We said it helps improve case management skills of the healthcare provider. And then it also help improve health system to provide quality care. So here, when a child comes to the facility, and then you're able to assess the child very well. You are able to do your physical examination. You're able to do your physical examination. You're able to communicate very well with the mother. It helps you to identify the case or the diagnosis of the child, and then you treat promptly to give quality care. Then we also said it improves family and community health practices for health growth and development.
Can you Oh,
next slide. This time, next, okay. So why was IMCI implemented? So we said the IMCI was implemented because children present with potentially deadly conditions at once. So a child may come to you with high fever, or with high fever, high temperature, and then you might not know what is wrong with the child. But then when you're able to do your assessment very well, you realize that this child may be suffering from malaria, this child might be having diarrhea, this child might be having cough or difficulty in breathing at the same time. So they come with deadly conditions. And then, upon your assessment, you might even realize that this child is very lethargic. It's dehydrated. So these children comes with what potentially deadly conditions at the same time. And then we said the second one is lack of diagnostic tools. That is labs and then radiology. So you go to a facility where there are no labs. You don't even have the laboratory tools over there. You go to a facility where now that we have the RDT, you may not even have the RDT. With some facilities do not even have HB to check the HB of this young infant. So it is brought to facilities with lack of these diagnostic tools. Then we said providers rely on patient history, signs and symptoms for diagnosis. And then they need to refer to higher level of care for serious illness. So this is why the IMCI was implemented. Then we said, is that Florence, the next slide. So in 1995, the World Health Organization and the UNICEF developed a strategy known as the Integrated Management of Childhood Illness. And then this IMCI integrates case management of the most common childhood problems, especially the most important causes of death. So the IMCI is to manage the most common childhood illness. As I said, the diarrhea, the cough, the pneumonia, the malaria, those kind of childhood illnesses. So this thing was brought together to manage those conditions in children. And then we know that diarrhea, fever, pneumonia, they are the common causes of childhood death or mortality among children. Why is IMCI better than single condition approach? So why don't we just go for the single condition approach? It says that it considers each child that is brought for health service in a holistic way. So in a holistic way, every child is unique. The child presents with a condition, and then you treat that child as he is, not boxing everything together. So you do your holistic assessment, everything about that child, and then you treat the child accordingly. Then we said the clinical algorithms takes into account the variety of conditions that may affect a newborn or child and put them at risk of preventable mortality or impaired growth and development. So you take these conditions into account, and then now you can segregate who are those at risk, who are those that I can discharge home early, and who are those that I can admit or retain in my facility, the ones that I'm supposed to give my pre-referral treatment to. So this, it helps you to segregate your children or your patients into where they belong to. Then it also focuses on effective case management and prevention of diseases, and contribute to health, growth, and development, including through immunization, nutritional, and development. So we are saying that it's also focused not just on the case management, but then preventable diseases. And what are these preventable diseases? These childhood preventable diseases, like the Hep, the DPT, the TB, the Rota, the pneumonia, they are the preventable conditions. So this IMCI came into play to take actually good care of those childhood conditions through immunization. Then we said all sick children aged up to 5 years are examined for general danger signs, and all young infants for signs of very severe diseases. Those signs indicate for immediate referral or admission to the hospital. So children under 5 years, any child under 5 years or any young infant are examined for general danger signs. And then it also indicates whether to give pre-referral treatment or to admit the child to the hospital. And then essential drugs are then used to treat the children or young infant. So here, after you've been able to identify the cause or the diagnosis of the child, you give the prescribed treatment to the child or for that condition. Then counseling of caregivers regarding home care, appropriate feeding, and fluid intake, and when to return to the facility. That is immediately or follow-up is done. So the principle is also to educate the mothers on the home care. It's not just about the health center, but then when they go home, what is expected of them, what they are supposed to do to improve the health of the child or the children in their homes, their appropriate feeding, the kind of food they are supposed to give to their children to help them recover early, prevent disabilities or yes, to prevent disabilities. So these are the principles of the IMCI. And then you also do follow-ups in the house. So it's either you go to their houses or or the mothers bring back the children to the health facility. Then we say children and infants are then assessed for main symptoms. For older children, the symptoms may include cough, difficulty in breathing, diarrhea, fever, TB, HIV, ear infection, anemia, measles, and malnutrition. I think I've explained this already. Then it's also a combination of individual signs, then lead to the child's or young infant's classification within one or more symptoms group. Please, the one writing on my slide should stop, oh, please. Please, the next slide. The next slide. Okay, so who can use IMCI? We said doctors, nurses, other health professionals who see young infants and children less than 5 years. So any health professional like the CHNs, yes. So they can also use the IMCI. And then it is a case management process for first level facility, such as the chief zones, the clinic, the health center, or outpatient department of a hospital. So the first point of contact of the child, whoever that is at that place, or whoever is available at that point, is the one or is someone who can use the IMCI tool.
I don't know.
Please, the next slide. So it says steps in integrated case management. And here we have 6 steps. So the first one is assess. So the assess means good communication with mother of child. So good communication with mother of child. When the child is brought to the facility, what are you supposed to do? You ask the mother the signs and symptoms that he exhibited in the house, the onset of the condition. When did it happen? How did it happen? What happened before the child started presenting these symptoms? Sometimes you can even ask what the child ate, where the child sleep. Does he sleep under mosquito nets? Has he ever had an episode of this condition before? So these are the good communication with the mother of the child. So you ask for these things from the mother, and then it helps you assess the child very well. And then you screen for general danger signs, which would indicate any life-threatening condition. So here, when the child is brought to your facility, let's say with diarrhea, what are the danger signs? That is the lethargic is there. You have the severe dehydration. Severe dehydration. You see that the child is, someone will say, the child is not moving, he's severely dehydrated. So those are the life-threatening conditions that you have to assess for. And then you ask specific questions about the most common conditions affecting the child's health. The most common conditions affecting the child's health, like the diarrhea, the pneumonia, the fever, and other things. Cough. And if the answers are positive, you do focused physical examination to identify life-threatening illness. So let's say a child is brought to your facility, I'll still go for let's say malaria. And then you look at the child, you took your vital signs, and then temperature was very high. You did your RDT. At that moment, within the first 1 minute, the RDT was, it has already reached, the 2 lines are already there. You look at this child, you realize that this child is not responding to even touch. The child is not responding to touch. So what are you supposed to do? Maybe you did your physical examination, you did your abdominal palpation, and you realize that you can palpate the spleen of the child. So you do your physical examination, and then you identify that actually the child is having complicated malaria. You ask them for the color of the urine, and the mother tells you that the color of the urine is dark colored. You should know that it is a complicated form of malaria. So that is a life-threatening illness that you have to look out for. And then evaluation of the child's nutrition and immunization status. So how do we know the immunization status of the child? By assessing their CWC cards. So you look through their CWC card. If the mother brought it, you look at it. Then last time he or she had the immunization. If not, you can ask the mother to the last time she went for CWC and then the kind of immunization that she was given, if only she can remember. Then the second step is classifying. So based on your assessment or the result of your assessment, the healthcare provider classified the child using a specially developed color-coded triage system. And we are going to talk about this color-coded triage system. It is the pink, the yellow, and then the green. And then we are saying that because many children, Susanna, please stop writing on my slide. We said because many children have more than one condition, each condition is classified according to whether it requires the agent's pre-referral treatment and referral, specific medical treatment and advice, or simple advice on home management. So your classification will now depend on your assessment and then the color coding. Then identify treatment. So after classifying all your conditions present, then the healthcare provider identifies specific treatment for the child, for the sick child or the sick young infant. Then if a child requires agent referral, as I said, it is the pink classification. So the pink classification, you give pre-referral treatment. In cases of complicated malaria, you give your artesunate, suppository artesunates, and then you refer. If it is high fever, the temperature is high, you give your suppository paracetamol. If the child is convulsing, you have to abort the convulsion before you refer. So you manage the child with your diazepam, and then before you do your referral, you don't just send the child away that because your case is complicated, you know, they should just go. No, you have to give your pre-referral treatment. And then the yellow one signifies that the child needs a specific treatment. So based on your assessment, based on your classification, you give what is required of the child. So that is where you do your treatment plan. You develop your treatment plan. Then the drugs to be administered to the child is identified. Then the last one, which is the green, is where the condition is actually not serious, that the mother can manage this child correctly or appropriately, or you educate the mother on how to take care of the child at home.
Please, there are too much noise at the background.
Next slide. Then treat. So after identifying the appropriate treatment, a healthcare provider carries out the necessary procedures relevant to the child's condition. So you give a pre-referral treatment for the sick child before being referred. And then you give the first dose of relevant drugs to the child who are in need of specific treatment. And then it teaches the mother how to give the oral drugs, how to feed and give fluids during illness, and how to treat local infections at home. So this one, it is specific. So now you know the condition, you've been able to diagnose the condition of the child. So you don't just give the drugs to the mother to send home. No, in your presence there, you give the first dose of the drug to the child, and then now you teach the mother how you're supposed to give the subsequent ones, the time interval, what you're supposed to do even before giving the drugs to the child, like washing of hands, feeding the child very well before giving the child the medication, you know, fluid replacements. Those are the things that you can do. Give your child copious fluid, continue breastfeeding your child. Those are the things that you treat them, you tell the mother. And then providers advice on the home management of sick children at home. Then if needed, ask the mother or other caregiver to return with the child for follow-up on a specific date. So this one, after your treatment, you ask the caregiver to bring the child back to the facility for follow-up. Or if possible, you yourself, you follow up on the child in their homes. Next slide. Then counsel, which is the fifth one. So we said if follow-up care is indicated, the healthcare provider teaches the mother when to return to the facility. And this one, it will depend on the severity of the condition. So some you may give a week, some you may give some few days. So it depends on the severity of the condition when it should come back for follow-up, so that even during that follow-up, you still assess the condition of the child. Is the child actually responding to treatment? Is he improving? How is he now? Like before he came to the facility, and then per what I am seeing now, is this child actually responding to treatment? So those are the things that, you know, you do when the mother brings the child to the facility for a follow-up. And then we said the healthcare worker also teaches the mother how to recognize signs indicating that the child should be brought back to the facility. So when you are discharging the child home, or the mother, the child with the mother home, you don't just ask them to go home. Eating excessively. If you go and then the temperature is still not going down, bring the child back to the facility. When you go and realize that the child is refusing to eat or refusing to breastfeed, bring the child back to the facility. These are some of the signs and symptoms. These are some of the signs indicating that the child should be brought back to the facility. So you educate them on that, or you hold them on that. And then when indicated, a healthcare provider assesses feeding, including breastfeeding practices, and provides counseling to solve any feeding problems found. So you also assess the feeding status of the child. You include breastfeeding if the child is still, if the child is still breastfeeding. You also educate on the 6-month exclusive breastfeeding. You should breastfeed the child exclusively to prevent other problems. Then counseling is also given to the mother about how to take care of health. So you educate your family. It's going to affect her, and it's going to affect Then follow up. Some children need a healthcare provider gives appropriate follow-up care as indicated in the IMCI guidelines, and if necessary, reassess the child for any new problems. So the follow-up is after you are done with your treatment, after the assessment, your classification, your treatment, your counseling, you now do follow-up. So as I said, it's either you follow up the mothers in their homes, or you ask the mothers to bring their children back to the facility. And then when they bring them back, you do your conditions. Maybe before you know, she went home, she came with malaria, but then she went home and had the child had diarrhea. She went home and then the child started having skin diseases. That she went home and then they started having ear infections. So you reassess for any other new problems, and then you treat accordingly. Next slide. Please, the next slide. So this is a sample of the IMCI case management. So as you can see, we have the focused assessment. So under the focused assessment, you have your danger signs. The main symptoms, the danger signs, and the condition that was presented, what are their danger signs? You look out for those danger signs. And then you ask for the main symptoms, or you look out for main symptoms of your condition. You assess the nutritional status of the child. Is this child able to breastfeed very well? Is it feed? Like what is the nutritional status of this child? Is the child malnourished or poorly fed? You look out for those ones. And then the immunization of the immunization status of the child. So you ask the mother, or you ask the mother to bring weighing kind of her CW child health record booklet to the facility, and then you go through the weighing column and see if the immunization column, to see if the child has actually taken immunizations, and then you look out for other problems. So after your assessment, you go to the classification. So as I said, we have 3 color codings. We have the pink, we have the yellow, and then we have the green. And then the pink stands for severe cases. So do I need to refer this child? So what I'm supposed to do before I refer this child? That is the pink one. Then the yellow treatment, after my assessment, after malaria. So let me give anti-malaria drugs to this child. This child is suffering from diarrhea. So let me give drug that will the diarrhea. You don't just, then you come to the home management. So when the mother goes home, what is he supposed to do after you have discharged them? After you have discharged them, what is he supposed to do? So you should continue with the treatment. You should adhere to the treatment. You should make sure that he finished the course. It shouldn't just go and you realize that the child is recovering, so it ends there. No, he's actually supposed to finish the course of the treatment. Then you identify your treatment, and then you give counsel, and then the mother, you do your follow-ups, and then that is it. Please, the next slide. So this is the IMCI case management at first level, or the referral and then home. So this one is just like the first one that I read. It also have the same color coding, but just that it's a bit detailed than the first one. So we said ask about child's problems, and then you check for general danger signs. Then you assess for main symptoms. Is there cough or difficulty in breathing? Is there diarrhea? Is there fever? Okay. You assess for malnutrition, then anemia. You check for other problems. And then after this, you come to your classifications. You classify the child's condition, and then you now identify your treatment. So the treatment still falls within the color coding. So if it is the pink one, you advise parents about referral. The reason why you are supposed to refer them, the need for you to refer them to a higher level, because my facility, I can't handle this condition. So they need to refer. There is the need for me to refer. And then with this, it's always advisable that in severe conditions, you do not just let the mother and the baby. If possible, you as the healthcare provider supposed to accompany the child and then the mother to the next level, or you call the referral facility to inform them of an incoming case or a child that you have referred. Then we come to the yellow one, which is the specific treatment. So you teach parents about the treatment, and then you counsel them about the feeding when they want to return. Then the green one is the home management. So now after this, we said what? Emergency triage assessment and then treatment. So that, as I said, the pre-referral treatment. And then you diagnose and treat common serious conditions. You monitor the patient progress. Then the next one is the home and then the family. So when it comes to the home and then the family, you give oral drugs and or treat local infections. And then you give food and fluids. So you give food and fluids. As a neonate, the only food you can give is breast milk. So you encourage the mother to continue breastfeeding, the child, and then you return to the health facility when needed, or you make a follow-up. And this was so please let's continue. So these are the health facility case IMCI case management. So we have general danger signs. So with the first one, we can say that the child is just lying down there, just like magic. The one under it, the child is convulsing. The third one, the child is refusing feed. And then the fourth one, there is difficulty in breathing. So these are the general danger signs that you are supposed to test for when the child will unit is brought to the health facility. So what are the advantages of IMCI? Why do we need to have this IMCI tool in our health facilities? We said it helps to speed up the agent treatment and treatment seeking practices. It also prompts recognition of serious conditions, hence prompt referral. It involves parents in effective care of the baby at home, because at the end of the day, you are going to counsel the mother, you are going to counsel the parent. So you involve them in the treatment care. You don't just do it all alone. And then it involves prevention of diseases by active immunization, improved nutrition, and then exclusive breastfeeding practices. Next slide. Please, next slide. Advantages considering. We said it is.
Lima and do you realize you are in class? What kind of attitude is that?
It is highly cost effective. And then it also avoids wastages of resources by using the most appropriate medicines and treatment. So you don't go giving the child or load the child with a lot of drugs, treating symptomatically. But then you are treating.
Salima, please mute yourself.
Identify the condition and then you are treating. And we say it also reduces duplication of efforts and then partial success of individual disease control.
Your mind.
Please, Sister Antoinette, please keep quiet. The challenges and adaptations of IMCI. So we said implementation. Please mute your mic, Sister Antoinette, Judith, Annan. So we said
they want to remove her. She's not ready to learn. They should remove her.
Challenges and adaptations. We said implementation of IMCI may face challenges in resources constrained settings, and adaptation may be needed to suit local context. Yes, resource deficient or facility, and then in a case of severe conditions, you may not get oxygen, you may not get the required drugs for treatment. The child came and then he needed certain things, he needs to run certain labs, and then they are not there. There is the challenge of you practicing IMCI over there. So that is it. So these are our references and then our group members. Thank you. Please, questions are welcomed.
Thank you, sister.
Thank you. Please, questions are welcomed. Any question for the group? Please, can we take off our slide if there are no questions? Okay. Yeah, it's Abu Bakari. But please, you are allowed to ask your question.
Okay, good evening, sisters. Please, community IMCI, there used to be those like doing it. There used to be community health volunteers too. That were also part of the health team that was doing it. I don't know whether they are still in existence. They were not health workers, but volunteers from the community. And they were giving some of the drugs, the emergency drugs like the ORS and those things, in case there is any childhood illness like diarrhea in the house. They can also manage before they come to the health facility. I don't know whether those volunteers still work.
Okay, thank you. They are no more in existence. So the volunteers are there, but the drugs are not forthcoming. So they don't manage cases in the homes again or in the communities again. That is from my side, but I don't know for other communities. But what I know is they are no more managing.
It's true.
Is any other question? Are we free to go? Okay, Mr. Salah Adams.
Thank you for your presentation. I would like to ask, the other time we went for a workshop and then we were told that now it is IMNCI, no more IMCI. So I was expecting to hear you mention that, but you didn't mention, you only mentioned the IMCI instead of the IMNCI. Thank you.
Oh, okay, thank you. Okay, the topic given to us is IMCIN. That is why when I was saying I added a unit, so the unit stands for the N. So the topic given to us was IMCIN.
Oh, okay, I didn't hear the N. I thought you mentioned IMCI, but I know the unit.
Okay, thank you. Mr. Vaida.
Hello. Please, I was hearing your concluding statement. You made mention that if you don't have oxygen, you cannot practice IMCIN. Am I correct or it was a mistake?
Yeah, I was talking about the challenges that are being faced by some facilities that are practicing the IMCIN, like the challenges IMCIN is facing. So I say that, you know, when the reason why I mentioned the oxygen as an example, not that if you don't have the oxygen, you can't manage an IMCI case. But the reason why I mentioned the oxygen is the challenges that IMCI tool is facing when it comes to certain facilities. So when a child comes with difficulty in breathing, that you are to manage the child with oxygen, you know, just allowing the child have to breathe on her own is not possible. So at the end of the day, you are supposed to manage the child with the oxygen. And if the oxygen is not there, you can't manage such a child. So it is a challenge facing IMCI, but that doesn't mean if you don't have oxygen at your facility, you can't manage IMCI. Please, it's a challenge. Have I answered you?
I was hearing it as if you don't have oxygen, IMCI cannot be done at that facility. Because I was also looking at it like the chip compounds. The chip compounds, we have limits. So if we don't have, we refer. So when I heard the ending part that if oxygen and what is not there, you cannot practice IMCI. I didn't hear the challenge.
Oh, okay. Okay, thank you. It's a challenge. Please, any more questions?
No, please.
No, please.
Okay, thank you.
Hello, sister.
Material.
If there are no other questions for for those who presented, the host will end the class so that we can begin the next class. Sister said you should hold on with your questions for the next class next week. Thank you. Hello, sisters. Please, can you hear me?
Yes.
Yes. So we are ending the class so that we can join the next class. If you have any question for those who presented, sister said you should hold on with it. Next week, she will answer all. Thank you.